So variable decelerations are most commonly seen during labor. This is, again, not necessarily a bad thing. What's happening here is compression of the umbilical cord. When ideally that umbilical cord should be between the legs and, kind of a deal. But, we can't tell, little fetus, A, B, C, and D, that their umbilical cord is going to be perfectly placed. So these umbilical cords are kind of free-floating, right, in the amniotic sac along with the fetus. Well, now potentially the membranes have broken. We don't have all of that extra cushion. The uterus squeezes. What is the uterus squeezing? It's squeezing everything inside. The placenta, the fetus, and also the umbilical cord. So we are occluding, during that uterine contraction, we are occluding the umbilical artery. So these have a very abrupt, a very sharp decline in the fetal heart rate. And then you're going to see a sharp increase, a rapid return as well. So you're going to see this most frequently in patients who have had a premature rupture of membranes, and they have that decreased amniotic fluid volume after the, membranes have been ruptured, right? There's less cushion. So these resemble a U, the letter V, or the letter W. These are okay, all right? These ones as well can or cannot be related, may or may not is what I should say, be related to the actual uterine contractions that are picked up on the tachometer. Prolonged decelerations. So prolonged deceleration is very non-reassuring, okay? This is, all right, we really need to intervene here, okay? We're no longer keep doing careful monitoring, we're intervening. So, for example, we're going to see these prolonged decelerations where we see rapid cervical change. For example, we have that precipitous labor, that baby is constantly being squeezed as it goes through the birth canal, and it's coming out very quickly. Very quick, rapid descent through the uterine cavity, through the pelvic cavity. If we have uterine tachysystole, so if our uterus is going nonstop, boom, 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 we're not getting that perfusion to the baby, we're going to see that prolonged deceleration as well. Cervical exams. Not everybody's cervix is real appreciative of having a cervical exam, so cervical irritability can also lead to a prolonged deceleration. Maternal hypotension. Okay, so remember when we talked about regional anesthesia, okay, and how we only use that in very careful, monitored situations? Well, this is why. We have maternal hypotension, mom's not being perfused well, and then baby, of course, is not going to be perfused well as well. And then artificial rupture of membranes. Perhaps baby is not being able to tolerate not having that extra cushion. So how do I know what is a prolonged deceleration versus bradycardia? Okay. So prolonged deceleration, when you're looking at this strip, okay, once again, I'm able to clearly see about 1, 2, 3, 4, 5, and most of the one far on the left, so most of 6. Okay, so I'm able to see in the first couple of boxes there, that first, whatever, last 50 seconds, 40 seconds that I can see, I've got a nice baseline of about 150 beats per minute. Now I have this prolonged deceleration where I'm dropping all the way down to about 80 beats per minute. And then I can pop back up, as you can see over on the far right. Now I'm popping back up to about 140 beats per minute. So this whole thing here, okay, is longer than, it's longer than 2 minutes in length for this prolonged deceleration. I'm starting to see it at that minute mark, 1, 2, 3, 4, 5. This is a 5-minute deceleration. It is less than 10 minutes though, okay? At Other than that, we would consider it a permanent change to the baseline and move it to bradycardia. Again, this combo of late decels, and if we really lose that variability, if we go minimal to absent variability, is particularly ominous. So this is a straight C-section if we aren't able to resolve it. So what are we going to do? Well, one of the things I'm going to be concerned about is my umbilical cord being compressed. So I'm going to do a quick cervical exam, making sure that we haven't prolapsed. We're also going to try to change that patient position, so the mom's position. We're trying to reduce any kind of prolonged cord compression that might be happening, prolonged asphyxia of the fetus that's occurring, or perhaps it's maternal aortic pressure. Let's go ahead and give an IV bolus. We're going to try to restore any kind of intravascular volume that might be depleted. Let's stop the Pitocin. I really don't want to put any more stress on this fetus than it currently is facing. Let's give some oxygen to mom. We're going to try to enhance whatever delivery that she currently has, get that as much as we possibly can to the fetus, and then we're going to prepare for that C-section. So how do you prepare for a C-section? Well, for starters, do you have an IV? Do you have one, or do you have two? Let's get 2 IVs rolling. As we start our IV, we're going to do a no-no, and we're going to pull blood off of that line, and we're going to get a type and screen, because I need it sent off right now. I'm going to drop a Foley. If I don't already have consent on file, I'm going to get a verbal consent for operative vaginal delivery or a C-section delivery. And in addition to that, I'm going to call a code for a neonatal code. Okay? And I'm going to get up with anesthesiology, respiratory. I'm going to end up with NICU personnel. I'm going to end up with labor personnel. And I'm also going to end up with the charge nurse if I have one, or the house soup. One way to help remember all of these is something called VEAL-CHOP. So this is an acronym. So our pattern is listed over there on the left. So variable is cord compression, but remember, it's okay. You know, it's umbilical cord compression. It's all good. Early is head, VEAL-CHOP. Acceleration is okay, and late is uteroplacental insufficiency, or P for placental insufficiency. And remember, that's not good. So this is just a handwritten strip kind of showing what the different contractions look like, okay, in comparison, or excuse me, not the contractions, the fetal heart rate. So again, we have variable, early, late, and prolonged.